Hello, Assalamu alaikum. My name is Dr. Muhammad Saif Ali Memon, and today my topic is about idiopathic thrombocytopenic purpura. So, the idiopathic thrombocytopenic purpura is a disease of platelets. So, there are many causes of thrombocytopenia. One of the most important cause, which is idiopathic thrombocytopenic purpura. So, when we classify the disease of platelets, which is thrombocytopenia, so we divide these conditions into many types. The first is due to splenic sequestration, which means that for any reason, if there is a hypersplenism, so there is more destruction of every cells like RBC, like WBC, and like platelets. The other is decreased production. So why there is a decreased production of platelets? It is due to primary bone marrow disorders like myelodysplastic syndrome, myelodysplasia, and acute leukemia. And there is also the decreased production of platelets which occur due to infections, which occur due to toxins, drugs, many drugs which decrease the function of the bone marrow, which suppress the bone marrow function, leading to thrombocytopenia, the B12 deficiency, the hypothyroidism, and the most important thing, which is the main topic today, idiopathic thrombocytopenic purpura, come into the heading of increased destruction. So there is non-immune and immune types. The non-immune means disseminated intravascular coagulation, idiopathic thrombocytopenic purpura, and thrombotic thrombocytopenic purpura, and von Willebrand disease. The immune types is immune thrombocytopenic purpura. So what is idiopathic thrombocytopenic purpura? The idiopathic thrombocytopenic purpura is a condition in which the antibodies are formed against glycoprotein 2b3a receptors. Glycoprotein 2b3a receptors. So these glycoprotein 2b3a receptors are present on platelets. The main function of the glycoprotein 2b3a receptor is to regulate the hemostasis, which means that it involves in the aggregation and adhesions of the platelets. So whenever there is a hemostasis occurs, so there is two things which occur most commonly. One is adhesion and one is aggregation. So the adhesion means that when the platelets are bound to the vessel wall, when there is a cut in the vessel wall, so at the site of cut or at the site of injury, the platelets are come towards the site of injury. This means that it is injury and the platelets are there, so they are coming to the sites of injury and they bound to the vessel wall through von Willebrand factor. So there is no any function of glycoprotein 2b3 receptor or less function there, but the most important function of the glycoprotein 2b3 receptor is that when one platelet is bound to the second platelet, it means there is an aggregation of the platelets occurs, so it is due to glycoprotein 2b3a receptor. So it is the most important function of the glycoprotein 2b3a receptor. So the antibodies are formed against the glycoprotein 2b3a receptor, which result into the premature removal of the platelets from the circulation. So which means whenever these platelets which are bound with the antibodies against the glycoprotein 2b3 receptors, when they goes through the circulation of the spleen, so splenic macrophages will engulf these platelets and result into the thrombocytopenia. So the main culprit or main organ which is responsible for this disease is spleen. Why main culprit is the spleen? Because the spleen release the antibodies, autoantibodies from the white pulp. As you know that the spleen have two pulps, one is a white pulp and one is a red pulp. So the spleen release antibodies from its white pulp, and these antibodies are attached to the glycoprotein 2b3a receptor, and the spleen also engulf these platelets through red pulp, and in red pulp there is a macrophage monocyte system which engulfs these platelets. So what is the most important organ involved in this? This is the spleen. So the disease is having two age groups. The disease is having two age groups. One is a children age group and one is a adult age group. So the children age group is due to viral infection. It is due to viral infection and it is of unknown etiology. Some experiment or theory said that the patient has autoimmune disease or connective tissue disorder. Autoimmune or connective tissue disorder. Okay, so as you know that the connective tissue disorder and the autoimmune disorder lead to the in some cases the theory says that it lead to the idiopathic thrombocytopenic purpura. Now the children age group has no any sex predilection. It can be into male or female, but in adult it most commonly occur in females. Okay, so it most commonly occur in females. Onset is of abrupt, means that it rapidly occur and it is only for 1 to 3 weeks, and it is self-limited. Self-limited means that if you don't give the treatment to the patient, so it will be all right after 1 to 3 weeks, but it is in insidious onset and it is a chronic form. It runs for many weeks to many months and it responds well to steroid. Means if you give the treatment to the patient, if you give the steroid to the patient in children, so it will respond well, but in adults it does not respond well to steroid. Okay, so this is the two disease course. After that, when we do the labs, when we have the suspicions of having idiopathic thrombocytopenic purpura, so we will do the labs. Okay, so one more thing which is very important to know, the clinical features and the sign and symptoms of the idiopathic thrombocytopenic purpura. So first of all we will do the labs. So in labs there is a smear having microsporocytes. Okay, microsporocytes. There is also Coombs test positive, which is also positive in autoimmune hemolytic anemia, because these both conditions are having the IgG mediated destruction of the platelets and RBCs, so it is also positive in this disease. And when we see the PT and APTT, what does the PT and APTT give us? That they give us the coagulation function. Okay, so the coagulation function is normal. There is no any defect in the coagulation factor or vitamin K associated factor, and also the liver is also normal. So PT and APTT will be normal, completely normal. The main thing which increase is bleeding time. The normal bleeding time is 2 to 9 minutes, but the bleeding time will increase to 17 minutes or 16 minutes in idiopathic thrombocytopenic purpura. When we do the bone marrow biopsy, so there is increase megakaryocytes. Why? Because whenever there is premature removal of platelets will occur, so the bone marrow has to increase its function to compensate for the normal values of platelets. But once the megakaryocytes will exceeds their function, so there will be no increase in the platelets, and you see that there is a thrombocytopenia in the blood. So this is the labs of the patient with idiopathic thrombocytopenic purpuras. Now, as you know that the conditions in which the platelets is involved, in this condition the platelets involved, so clinical features are petechia, purpura, and ecchymosis. There can be GI bleed, there can be CNS bleed, which is lethal for the patient. There can be retinal hemorrhages. There can be epistaxis, bleeding from nose. So these are the clinical features of the patient which comes in the idiopathic thrombocytopenic purpura. So what is the management of the idiopathic thrombocytopenic purpuras? The management depends upon how many platelets are present. The normal value of the platelets is 150 to 300 lakh 300,000 normal value of the platelets, multiply by 10 power 3. But if the platelets value is less than 30,000, so you have to do the treatment of the patient. If the platelets value is greater than 30,000, so it is not necessary to give the treatment to the patient, because there will be no bleeding in the patient who is having a platelets greater than 30,000. So if there is a mild bleeding and platelets count is less than 30,000, so you have to give the only glucocorticosteroid. Okay, which is prednisolone, which is dose is 2 milligram per kg per day. You have to give the patient, and there are very much good results when you give these steroids, prednisolone, to the patient which is a childhood patient, and there is a well response to glucocorticosteroid, and the patient will having normal platelets within 1 to 3 days. But if the patient is having a severe bleeding, or bleeding occur from the CNS, or bleeding occur from the GIT, or bleeding occur from the retina, so you have to give the patient glucocorticosteroid. It is not enough to give the patient only glucocorticosteroid, so you have to give intravenous IgG. So what happen? Intravenous immunoglobulin G will do, it will bind with the Fc receptor of the antigen antibody complex. So these IV IgG will not cause the premature removal of the platelets. They will prevent the platelets from the premature removal of platelets from the spleen. So we have to give IV IgG. Okay, if we give these all things and after that there is no any improvement, so you have to do splenectomy. But before splenectomy, you have to do the vaccination to the patient, because the spleen is having a very important role in defending the organism which are very harmful to the person. So what vaccination you have to give? Haemophilus influenza, pneumococcal, and meningococcal. And you have to give the prophylaxis penicillin V every day for life. And these vaccination you will not give intramuscularly, because there is a chance of hematoma formation, as you know that the platelets are very less in this patient. So you have to give these vaccination in the form of subcutaneous injections. Okay, so you have to do the splenectomy, and after that, if the splenectomy cannot, in 70% of the patient the splenectomy is effective, but if the splenectomy is not effective, so you have to give other drugs like romiplotism, which is thrombopoietin analog. What is thrombopoietin? The thrombopoietin is a substance which is involved in the formation of the platelets, which induce the bone marrow to release more platelets. So the romiplotism and iltrombopag. It is also the thrombopoietin receptor analog. Okay, and other conditions like, as you know, the monoclonal antibodies, which are the human antibodies, rituximab, we will give to the patient. So this whole is about the idiopathic thrombocytopenic purpuras, which is self-limited in children, but in adult you have to give the treatment, and this condition is more serious in adults, not in children. Okay, thank you very much.